Hi, good evening. My name is Rakisha Wilson, and thank you for attending tonight's Ask the Experts virtual event on obesity and weight loss management. And I'm Dr. Rakisha Wilson, a metabolic and bariatric surgeon at Cleveland Clinic. Joining me are specialists from Cleveland Clinic's bariatric surgery and obesity medicine team. So I'm excited to introduce my colleagues in a second. So we're here tonight to answer your questions and provide details on obesity management and weight loss topics, including medical and surgical options, diet strategies, mental health considerations when starting your weight loss journey, and nutrition and diet guidance. We had nearly 200 questions submitted by our audience, so we'll do our best to answer as many questions as we can. And also, we'll send out an email after the event that includes resources on obesity, medicine, and surgical weight loss to those who registered. So, with all that said, let's take a few minutes to do introductions, and then we'll have an opportunity to dive right into your questions and answering those in that portion of the event. So, again, to kick things off, my name is Dr. Rakisha Wilson. I'm a metabolic and bariatric surgeon and also tonight's moderator. I've been in practice at the Cleveland Clinic for 4 years. I'm originally from Texas, but I moved here for my Cleveland Clinic bariatric fellowship and have been practicing since 2021. One of the most common questions that I get around weight loss and metabolic surgery is, what's the recovery like? And so I usually tell people, actually, it's a one night stay in the hospital on average. We use small incisions, and usually people can get back to work in 2 weeks. Some people may require more time off, but that's probably the most common question that I get. And a way that I maintain a healthy lifestyle while being a busy surgeon is to make sure I lift weights, I hit the gym, and also I have to watch my sweets because I have an extreme sweet tooth. And so that's a little bit about me. Next on the panel, I'd like to introduce my colleague, Nini Peterson. Dr. Peterson, take it away.
So hi, I'm Nini Peterson. I'm a clinical and health psychologist with the Bariatric and Metabolic Institute. I've been practicing for 13 years and have been at the clinic for 9. I work on main campus and at the Twinsburg Family Health Center. I'm actually part of a team of 7 psychologists, and we evaluate and treat our patients who are seeking surgical and or medical treatment for their obesity. And I really love what I do. My healthy behavior, and I'm really, really proud of this, is on Sunday night, I open up my calendar for the week and I choose 3 days and commit with intention for exercise. And then I kind of pick a 4th day. My goal is always 4 days, but I commit to 3. And then I have a 4th day that may be a little bit touch and go.
I love it. That's beautiful. Thank you so much, Nini. Next, I'll have my colleague, Kristen Loudon, to introduce herself.
Thank you, Rakisha. My name is Kristen Loudon. I'm a nurse practitioner in the Bariatric and Metabolic Institute. I've been in my position for the last 5 years. I see patients in Avon, Westlake, main campus, and also virtually. I specialize in obesity medicine. And my secret to staying active is to make it fun. I like to play volleyball. It's sand volleyball season right now. I also have a 6-year-old, so she keeps me busy. And we've been doing a lot of swimming and bike riding recently.
I love that. Excellent. And also my colleague from nutrition, Lindsey Bechter. Introduce yourself.
Hi, my name is Lindsey Bechter. I've been a dietitian for 5 years, and 4 out of those 5 years I've been at the Bariatric Center at Cleveland Clinic Akron General. I see patients at the Akron office, virtually, and in office. And it's been a very fun journey here. And my secret to staying, I guess, on healthy and active is my dog. She always wants attention, very attention seeking, and she's the one to tell us, okay, it's time to get out there. It's time to do things, Mom, let's go. So it does make it more exciting when you have a little being holding you accountable.
Excellent. Thank you all for those introductions. So now it's time to answer your questions. Again, we received almost 200 questions, including topics ranging from weight loss medications to diet and exercise, and when to consider surgery. So we'll attempt to answer as many as we can for the next 45 minutes. And so to start, I think we probably have in our audience multiple people who may be trying to learn more and just considering treatment options, the various treatment options for them. So I think to each of the panelists, I just want to get your thoughts on when do we know that it's time, or when does someone know that it's time for them to consider treatment for obesity or weight loss? And I'll start with you, Kristen. What would you say? When is it time? When should someone consider treatment for their weight and their health?
I have a lot of patients who tell me, they know their body tells them, right, that it's harder to do things that they love to do. They want to play with their grandkids. They want to get out if it's impeding their everyday life, or if they're put on blood pressure medication or cholesterol medication, or they're not sleeping well, or they have been found to have diabetes. These are instances when we maybe need to intervene with medication faster than we normally would. And lifestyle interventions are wonderful, but unfortunately not effective for larger amounts of weight loss long-term for most patients.
Excellent.
And I would say, adding on to what Kristen said, that distress and disruption to functioning, but come in and ask, have a consult and just have the discussion about that. People may not be ready, or what they think is ready may not be what we can offer. We're at an exciting time where we have a whole menu of options. And so come in, make an appointment, have the discussion, and we go from there.
Excellent.
And even on top of that, a lot of the patients that I see, they've never met with a dietitian before. So it's a first time experience. So even being able to, like Kristen had said, other interventions and kind of navigating that, and maybe something's not working and you've been trying for a long time, and kind of asking those questions of what are my other options? And hopefully, whoever you're speaking with, whatever provider you're seeing, has other resources for you to further look into, whether that's surgery, non-surgical, asking the questions is important.
I'm going to jump back in with that.
Yeah, please do.
Lindsey, the same thing for me as a psychologist. Many of our patients have never seen a psychologist. And so one of those questions is, why am I seeing a psychologist? I'm not crazy. And that's not why we have psychology embedded in our program. We are looking at people's strengths, and we look at things they may struggle with and come up with a treatment plan that's combined with our providers. We work with the dietitians, we work with the medicine team, we work with our surgeons, and our job is to help people feel comfortable and confident with their decisions to optimize their long-term and short-term and long-term success.
Excellent. Thank y'all for that insight. Were you going to say something, Kristen?
Yeah, I just wanted to add that just because someone's overweight does not mean that they're not healthy, right? So when someone needs an intervention might be different than someone else. And someone who's only slightly overweight may need an intervention earlier than someone that is more overweight. So we're all different. Obesity is very different in everyone.
Absolutely. And just to really add to what my colleagues have said, I think education is your power. That's the empowerment. And so I know many of you may have only thought about seeking treatment when a provider brings it up. Some of you may have had friends or family members go through it, and now you're wondering about yourself. So as soon as the thought comes up, if you're curious, educate yourself. Ask your provider, maybe your primary care provider, maybe the most common provider you see. Ask the question so that you can empower yourself with education and the knowledge. And having webinars and events like this is excellent. And we have so many resources, even in our program at Cleveland Clinic, to equip our patients with that knowledge and power. So I'll take on one of the questions, common questions that we got. And that is, what's the difference between the weight loss surgeries? And so I know a lot of people think surgery or medication when they're kind of seeking treatment. So I'll start off on the surgery side just with a breakdown. There are several different types of surgeries or procedures that we do, and we call it metabolic surgery, although it's known as bariatric or weight loss surgery, because this is treatment really for your body, for your health overall, not just for your weight or a number on the scale. And so, just briefly, there are two of the most common procedures that we perform. That's the sleeve gastrectomy and the gastric bypass or Roux-en-Y gastric bypass. By and large, those are going to be the most common procedures that will be discussed and offered. So, the sleeve gastrectomy and all of these procedures are done with small incisions. And again, it's minimally invasive. That's what it means by small incisions. It's usually a one night stay in the hospital. Recovery is around 2 weeks. And so the sleeve gastrectomy makes your stomach smaller. So we take out about 70 to 80% of the stomach, take it out of your body. So your stomach goes from a balloon shape to a banana. That's the simplest and most common procedure. People lose about 25 to 30% of their body weight. The Roux-en-Y gastric bypass is a more complex procedure, but also safe, done with small incisions. Recovery is similar. And that's where we don't remove your stomach, but we exclude your stomach and make a small pouch from the top of the stomach, and we connect it to part of your intestine. Okay, so we're bypassing or skipping the majority of your stomach. And so these procedures impact your hormones and the way the gut and the brain communicate, and they can regulate your weight and appetite in different ways. And so those are the main difference of two of the most common procedures. And again, everybody's weight loss expectations are going to be different, but we're seeing improvement in diabetes, sleep apnea, what else? Heartburn or reflux disease in some cases.
Liver function.
Yeah, your liver function, if you've heard of fatty liver disease, the name is changing, but multiple health conditions, multiple joint osteoarthritis. Some people are qualifying for procedures they weren't previously qualifying for because of the significant weight loss. So our goal is improvement in your quality of health and your quality of life, much more than what the scale says. And so I think one of my colleagues brought that up, and that's a great point.
And we know obesity is related to at least 7 of the top 10 leading causes of death. Cancers, it's related to at least 13 cancers. And so improving overall health and quality of life is really important to our entire team.
Yes, excellent point. And I was blanking, but high blood pressure, obesity-related cancers, multiple medical conditions that many people have that they don't realize is related to their weight or their obesity. And those medical conditions can improve with significant weight loss. So Kristen, let's talk about what everyone's talking about, GLP-1 medications, of course. So let's see. How do GLP-1 medications like Ozempic, Zepbound compare to each other and to bariatric surgery in terms of how effective they are and long-term outcomes?
So, contrary to popular belief, GLP-1s are not willpower injections. These medications are synthetic versions of the hormone GLP-1 that already exists in our body, but being deficient in it can cause us to gain weight. GLP-1, the hormone, slows GI motility, it makes you feel full, and it regulates insulin and blood sugar. These newer medications or second generation medications for weight loss are medications such as Wegovy or Zepbound. And Wegovy and Ozempic are both semaglutide, but Wegovy is FDA approved for weight loss and Ozempic is FDA approved for diabetes. They are the same active ingredient, but marketed for a different reason and put in a different pen and may have slightly different dosing. Another medication similar is Ozempic and Wegovy. They're both semaglutide, and then Zepbound and Mounjaro. Mounjaro and Zepbound are both tirzepatide. Mounjaro is also FDA approved for diabetes, and Zepbound is FDA approved for weight loss. Zepbound also has a new recent indication for moderate to severe sleep apnea as well. But just because a medication has FDA approval for an indication does not mean your insurance will automatically cover it. At 68 weeks with Wegovy, the mean percentage weight loss was about 15%. And at 72% in adults without diabetes, Zepbound produced at 15 milligrams about 17 to 21%. So you can see that these medications are highly effective and they've come a long way. But bariatric surgery is still the gold standard for weight loss intervention in patients with severe obesity. Kind of like we have snow in the driveway. These medications, before we were out there with the shovel, the first generation medications, such as Qsymia and Contrave. And these are still cost-effective possibilities for patients. So don't rule them out, especially if you do not have that much weight to lose. But if our patient has a BMI over 40, then we may need to call in the plow. And these newer generation medications are our new snowblowers, right? So depending on the patient and their comorbidities and what they weigh, we're going to have a different response for each patient. And both surgery and medication have pros and cons. And they're both considered safe overall in the right person.
Absolutely. And, at a recent conference that we were at, and I learned from my colleagues all the time that we're trying to get away from, hey, do you qualify or are you a candidate for surgery or this treatment? We want to educate you so that you can decide comfortably, hey, is this the right fit for me? And we want you to think about it in those terms. And so knowing all you can about all the treatment options is really going to be important. And the nutritional and psychology component will help you answer that question. Is this a right fit for you based on what I know about myself and what I'm learning throughout the program? And so I think those are great points that you bring up. And when we say percentage weight loss, for example, if you're 250 pounds and 5'4", let's say that. So your BMI or body mass index is 42. That qualifies as having severe obesity. So for example, if you lose maybe 15 or 20% on the newer medications, you may get down from 250 to like 210 or 205. If you got the sleeve, 25 to 30% weight loss, that might get you down to the 180s. With the gastric bypass, 35% weight loss, that might get you down to the 160s to 170s. And these are just estimates based on our research and outcomes studies. Everyone responds differently. Some people can do more or less based on their lifestyle, based on their medical conditions, and maybe their limitations physically. So keep that in mind. So just to move forward to my colleague, Lindsey Bechter. So a lot of people are curious when they join nutrition programs. I get the question a lot of like, oh my gosh, how much weight are y'all going to make me lose? What do I need to do? So one of the questions was, what are some tricks to get through the first few weeks of a weight loss program? And I'm thinking that's not just after surgery, but even starting a program. How do you get through it? What can people expect?
Well, my biggest suggestion and even recommendation is break down your goals. In the way that I explain it to patients when I meet them for the first time, it's almost like I give them a checklist of things on the nutrition side of the program of what they need to kind of work on and start incorporating in their day-to-day. And that list can look really scary. That's a lot of things that maybe you haven't done before, or it's new for you, or you have no idea what any of these things are. And that's what your dietitians and the rest of your team, your medical staff, your psychologists, your surgeons, like all of those people have a big part to play in this too. So first, I would say break down your goals. Figure out what is going to be maybe the easiest or the simplest thing to kind of accomplish first, and then kind of work your way slowly to maybe the more harder things. Maybe exercise is like really tough for you and it's just not your thing. And you're like, I don't know how to incorporate this, but I can focus on drinking more water for now. Okay, well then that's a victory in itself. We'll work on that for X period of time and then come back to your team and tell us how you're doing. But that's how I would try to, I usually tell people, break it down. Don't try to do it all at once. That's a lot of change at once. Make it simpler.
Lindsay, as a psychologist, I 100% agree with that. We have people that kind of say they're waiting for the motivation to start with a goal. And I say, take a page from Nike and just do it and let the motivation catch up with you. But I like starting with the things that are easiest and building up confidence for sure.
That's a great.
You want to make it realistic.
Mm-hmm.
That's a great point. I understand that I'm not on video at the moment, but I'm working on that. Can y'all still hear me?
We can hear you, and
We can hear you.
Yes.
Okay, excellent. Hopefully I'll make it back on the screen soon. But a question for you, Nini. What emotional or physical, what challenges should people expect when they start a weight loss program? Like you mentioned, many people think, why do I need to see a psychologist? Or look, I'm gonna just fake it, during that visit and whatever. What should people expect when they talk to a psychologist in the bariatric program?
I mean, one of the things to remember or learn, obesity is like chronic, it's complex, it's nuanced. And so what we've heard for literally thousands of years is eat less and move more. And if it was only those two things, we wouldn't be having this conversation. Today, we wouldn't exist as a department. So having a discussion with your clinicians regarding expectations about what does the treatment actually entail. Tell me more about the outcomes, the average outcomes that you just mentioned, the pros and cons. And the second thing would be also discussing specific goals. Lindsay kind of jumped onto this already. So patients, when they're starting something, they're motivated, they're excited, which is awesome. We want to channel that motivation to make it more helpful. And again, just repeating what Lindsay said, patients also tend to set weight loss goals, right? And we want to aim for behavioral goals, looking at success more broadly. Non-scale victories are the other things in there. But having open discussions can be really helpful with that.
Yeah, absolutely. I love that. And I think that people don't realize that a big part of not necessarily qualifying, but making sure you're fit for surgery is really being self-aware and really being prepared mentally and emotionally for the journey ahead. And the journey's lifelong. So I think our psychology colleagues do a great job of bringing that to light, which is wonderful. There's another question I'll ask while I'm invisible on the screen still. And so that is, who is not a candidate for weight loss surgery? And so I'll say that's an excellent question. And I'll say a couple things. So number one, anyone who isn't comfortable during the process with committing to the discipline that it takes in terms of like vitamins and being compliant or understanding maybe some of the dietary restrictions that you'll have after surgery, and even any discomfort in leading up to surgery. If people are unsure and really can't get to being confident that this is the right treatment option for them, they won't be a great candidate for surgery. And I think otherwise, someone who has uncontrolled medical conditions because of maybe poor health choices or decisions, I think they may not be fit. And so if you have, per se, uncontrolled high blood pressure, we have to get that under control, or you may have a stroke after surgery. So that kind of stuff is more straightforward. Or someone with congestive heart failure or other things that are out of control. You want to be fit for surgery and prepared to undergo anesthesia. So I think it's critical that, and that's why you undergo several appointments, testing such as chest x-rays, EKG, basic blood work. We really do a complete workup and physical check-in with you, and you meet with our medical practitioners and providers to really assess your overall health and get a picture. We're not just trying to do surgery on everybody that we can who comes through the door. we really want to consider and assess if this is the right fit for you. And you have to be fairly stable and overall healthy to undergo surgery. Now, some conditions aren't controlled because of obesity and because of the severity of obesity and the disease. And so, diabetes, for instance, can get more and more difficult to control the higher your weight is. And so, I think in those instances, will allow a level of maybe poor glucose control, knowing that surgery will significantly help those individuals. And so I think that's something that's important, and I think that was a great question from our audience. Um, Going back to the medications, so are the GLP-1 weight loss drugs safe for short or long-term use, especially for those with other health conditions?
So far, we have long-term safety data up to 2 years for semaglutide and up to 3 years for tirzepatide that showed no increased risk of death or major adverse events. But we're still waiting long-term data from these trials. And unfortunately, weight recurrence is common if any of the medications are stopped. So that indicates the need for ongoing therapy to maintain the benefits. It's kind of like a thermostat, right? So the medications lower the thermostat, but if you take the medication away, it'll get hotter in the room. You can open the window, but the furnace will kick on.
Okay, I think that makes a lot of sense. I'll jump to you, Nini. Do mental health issues interfere with bariatric surgery? And I'll have y'all discuss that. I may log off and log back on, but yeah, take that away.
Sure. And this is kind of going back to what we all said. It's an interdisciplinary approach, and you meet with all of us to help you optimize. We are never looking for perfection. You don't have to be perfect to get to surgery. You just have to be optimized, right? Safety, for your safety. I would say from a psychological or behavioral health standpoint, my big 3 ticket items that I'm looking at would be first, psychiatric stability. Specifically, if somebody has had a suicide attempt or suicidal ideation, a gesture within the year, that would be kind of a timeout. We want stability under your belt because we know surgery does not, my surgeons are not operating on your brain, and life stressors happen. If it happens the year before, it's more likely to happen the year after. So we want to see a nice period of stability. We want to make sure patients are adherent to medications and to counseling appointments if they need that. The second big ticket item would be eating disorders and disordered eating. Eating disorders, we see specifically binge eating disorder. It's not what we call a contraindication for surgery. We wouldn't stop someone, but we know that people who have that addressed prior to surgery tend to have better outcomes. So that may be something that we're looking at beforehand. The third big ticket item would be substance use. So alcohol, nicotine, cannabis, recreational drug use. If somebody has a substance abuse disorder or an alcohol use disorder, that would be a timeout for surgery. It's not no never, but timeout. Let's get those things managed under control. We want to see a year of stability, treatment, and we'll come back and reassess in a year. We are also looking at your knowledge, your expectations, and that's a discussion. We're looking at people's support systems, behavioral adherence to CPAP regimen, medications, and other things in there that can help them.
Excellent. And that's a good point when you talk about addiction, because one of the contraindications that I didn't mention earlier on who wouldn't be a good candidate, addictions, of course, but smoking addiction, we see that a lot, and that will impact not only if you can have surgery, because in our program, especially for nicotine use, we have you tested and to make sure you've stopped smoking, for instance, for a period of time. But we know that you can stop for surgery if you're motivated enough. But what about after? So even people who've had long-standing nicotine addiction and smoking habits, I will I will recommend the sleeve sometimes instead of the gastric bypass, because we all know life happens. Things can get stressful. You may have loss or grief, and you can go back to those habits, and that can be really dangerous after surgery. For instance, I've had patients who had the gastric bypass had gone back to smoking maybe a year after their surgery, or people go back to drinking alcohol like they used to, and before, and those patients may develop ulcers that affect how they can eat, drink. You get hospitalized. There's a lot of risk to addictions that are uncontrolled. But we even take a history of those addictions to even determine what procedure might be safest, just in case you were to fall back into some of that. And so I think that's a great point about addiction that you bring up, for sure. Okay, Lindsay, some more nutrition questions. What part of the diet or what component is the most important? Should people focus on the fiber, protein, the carbs, sodium, sugar? What should people be avoiding? What should people be looking into before surgery or before treatment and after?
So good question. There's a lot of pieces to that question, but the one that I would really focus on is the added sugar. So when they revised the food labels, they started telling us a little bit more between just sugar, and now we have total and added. And added is telling us, hey, this was not natural to this product. You're going to see natural sugars in your fruits, sometimes dairy products, those types of things. They're naturally occurring. You don't see natural sugars in candy or ice cream or cookies and things like that. They're sweet treats that we all enjoy occasionally, especially in the summertime, which we understand. But if this is a common habit that you may have, or maybe there's just a lot of sugar in the house and it's really tempting all the time, that's definitely something that we talk about prior to surgery, and kind of navigating how to understand, how many added sugars are kind of in our diet and how they're adding up, as they could have negative effects not only before surgery, but after as well. And to kind of dive into the after effect. So with having bariatric surgery, you're at risk for having something called dumping syndrome when you eat something that's high in added sugar. And it's not a great feeling from what I've heard patients describe. It's not something that they ever want to go through again, but it's almost like your body cannot handle that sugar. It's just digesting too quickly. So to really pay attention to our food labels ahead of time, and understanding, okay, my ketchup has added sugar in it, probably should keep that out of the house. Given after surgery, what happens if I want that and I accidentally eat that? Even like the small things like that, just kind of paying attention to those things. And that's something I really focus on pre and post-op overall.
And I know we focus a lot on, and I think y'all do such a good job of educating our patients, because after surgery, even I see them a year after, and they're like, I'm trying to get my protein in. I'm eating my protein first. I mean, do you always have to think about that, like even long term after treatment?
Absolutely. So protein's super important, but there are other points of your intake that are also important, just like vegetables. Okay, so that fibrous piece of your plate. So we teach the plate method, which is, your protein, then half your plate's non-starchy vegetables, and then you've got a little bit of a carbohydrate. So we want to make sure overall, and again, this is pre and post-op, but you could have asked Dr. Wilson specifically post-op. Protein's great, but we also want to make sure that we're incorporating variety. Protein and veggies slow digestion down so that we can enjoy a little bit of a carbohydrate as well, as we need it for our brain and our exercise. But at the same time, we're creating good portion control, moderation in what we're eating, and staying full in between meals. So if we can pair it that way and make sure that we're kind of spreading the wealth, we usually see successful, outcomes long term, because we want to visualize that plate best we can. And it looks different for everybody in some instances, given what they can handle and what they can't.
I think those are great points. I tell patients all the time, we can't beat liquid sugar. We just can't do it. None of this is magic. We are only talking about tools, okay? But these tools are only as good usually as the work you're putting in, the discipline you're exercising. And we don't want to really throw you off the rails and have you in boot camps and doing diets that aren't sustainable. But really, your lifestyle choices, long term, even after whatever treatment option you choose is best for you, is really going to be critical. And I know patients worry a lot about protein after surgery, but you need protein to build muscle. And I really encourage people after surgery, lift you some weights. Okay. Get the weightlifting, get stronger and healthier. Because we're not trying to get skinny. Okay. We're not trying to get down to the lowest number on the scale. What's more useful is how fit you are. Okay. As we age, if you have a slip and fall and it's just bone on concrete, that's going to be a problem. But if you have muscle, if you're fit, if you get pneumonia or catch something in the hospital, your physical fitness is going to have a significant positive impact on your recovery from multiple conditions and things you might experience. And so you're getting the protein in, focus on that, but think about the why. What are your goals, long term? Okay. Glad to be back
And
and
just
be seen on camera too.
Just to add to that, Rakisha, strength training is also very important with these medications. So when we have more muscle, it impacts our metabolic rate, and it's much healthier overall to not have as much, fat in our organs that can impact their function. So whether you're, contemplating surgery or medication, strength exercise is important to reduce muscle loss with weight loss.
I'm going to roll.
Yeah, go ahead.
Sorry.
Go ahead.
I'm going to roll that into the non-scale victories also. That's a great one for strength. I've had patients standing on a scale outside my office. They're pulling their pants up saying, why is the number not going down? Why am I not losing weight? But they're forgetting about changes in body composition, strength. And again, when we talk about success, we do want to look at it broadly.
Yeah, even if the scale doesn't move, if you lose inches in your waist, you're metabolically healthier and your risks go down.
Absolutely.
Every week I see patients who come in and, the last thing I talk about is how much weight you lost, to be honest. What are the things you notice you can do? I can make it up and down the stairs. I can chase my grandkids around or my kids around. I know I couldn't go swimming with my daughter, or, that's your why, really not the scale. And people forget, I no longer have to inject insulin every day. I'm actually on only one blood pressure medication. I was on 3. So those non-scale victories are so important. And your overall health should be really, that's how we would recommend you measure your success, not just based on the number. And I think your satisfaction with your outcomes will be better too, for sure. And that kind of rolls into a super common question that I get for people when they're thinking long term. How much excess skin am I going to have? And so, that's obviously hard to predict. Everybody's skin will kind of contract differently and at different weights and rates. And so it's hard to answer, but you may, in fact, many people do have some sort of excess skin, but a lot of people are forgetting a lot of our weight loss comes from muscle loss. And so first off, if you're toning up and building your muscle, first of all, is heavier. Muscle weighs more. So your numbers are going to be impacted by that, but in a good way. But also, that's a way to get toned and to manage some of that excess skin. But overall, a general policy at our program is at the 1-year mark, when you have your follow-up and usually see the surgeon, we can refer you to a plastic surgeon to discuss options for managing excess skin, and especially if it is causing irritation, discomfort, and affecting your quality of life. That makes it even more possible and medically indicated, and they can talk to you about whether or not insurance would cover something like that. But we do have resources and can help you after if you're dealing with excess skin and you're uncomfortable with that.
And I'll throw in a plug for our team. We have 7 psychologists on our team. If you're dealing with some of the emotional components of having excess skin, it's affecting your distress, it's affecting your behaviors. You're not going out, right? It's affecting adherence.
Mm-hmm.
So come in and talk to us.
Yeah, and that kind of rolls me in, Nini, to and for everybody to chime in. And this was not a canned question, but what is the long-term follow-up? Do people just get treatment and get surgery and then it's peace out? How can people expect to stay connected, stay encouraged on their journey? Are there support groups? What's that look like?
So we do run support groups twice a month that are virtual, and we do expect our patients to come back to see us. We're not a program that says have surgery, bye, good luck. We're here for the long haul. I've actually started telling my patients that, by the way, you've signed up for a marriage with our team. Surprise. And you're going to have a lot of appointments. We see people, the surgeons see them 7 to 10 days after surgery. We have a 2-week post-op with the dietitians. 1 month they're scheduled with obesity medicine, surgery, psychology. The dietitians, again, we have 3 months, 6 months, 1 year, and we expect to see you yearly for the rest of your life. And even if your health is perfect, you're not on any medications, you feel amazing, you should come back at least see obesity medicine for lab work at least once a year and come in and check in with the rest of our team. I call myself a car mechanic. If people just need to come in for a tune-up or an oil change, come in, check in, even if it's once a year, and we can kind of make a plan for there.
And Nini,
And
to
with
bounce off of that,
obesity,
go ahead. You
Oh,
go
go
ahead,
ahead.
Kristen.
With obesity medicine, I like to see them annually at least, and I like to prevent weight recurrence if I can. Some weight recurrence is inevitable, whether it's medication or bariatric surgery, but we have a lot more options for interventions earlier. It's easier to prevent weight gain than it is to treat it. And a lot of people who've had bariatric surgery might think, be ashamed because of weight recurrence. And it's not their fault. This is a chronic, relapsing, progressive disease. And even my patients that don't have bariatric surgery, right? We can have weight recurrence, and it's not your fault. This is a complex disease to treat. And like I said, it's better to intervene before we gain the weight back and intervene aggressively than it is to sit back and wait and try to treat it later.
On the nutrition side of things, we see patients consistently, monthly pre-op. And we get to the point where like, okay, so you're ready for surgery. I'll see you after. And a lot of people ask us like, am I going to see you after? Absolutely you are. You're going to see us pretty frequently. And as Nini had said, there is a follow-up schedule, but we're also seeing a little bit more close follow-up lately. And it's been way more successful long-term for sustainable weight loss and weight maintenance. And I encourage that 100%. We're your team. We're here for the long haul. We don't go anywhere after surgery.
So as Lindsay was saying, you don't have to wait for those milestone 1 month, 3 months, 6 months. If you need something in between, come in, schedule.
Absolutely.
And life happens, right? Like having pregnancies or menopause or, those are, if we have nutrient deficiencies, sometimes those can lead to weight gain, like anemia. So intervening and doing a panel and digging deeper into why what's happening is happening is incredibly helpful, whether you've had surgery or not.
Man, great points. I'm taking notes from y'all. And again, for our program for follow-up, it's easy to do. We have in-person and virtual options. And so you can schedule from your MyChart or just call our office to get scheduled. So you have so many options for follow-up. And just know you're not bothering us. I've heard patients say, oh, I didn't want to bother. I didn't want to do, it's not a bother. We really want you to reach out because we care about your journey and your outcomes and how you're doing. And so I had a couple questions and notes. So Kristen, I think people think about medications or surgery, one or the other, but what about combination? therapy, I mean, can people take medications leading up to surgery or after surgery, or is it one or the other?
We are finding that weight loss before surgery is improving outcomes for patients after surgery. A lot of people want to try medication before they're ready to commit to surgery. So when I first got this job, I honestly thought I would save everyone with medication and no one would need surgery. And I have been humbled. Okay, these medications are powerful, but they have limitations, and we have to be realistic with what they can do. And not everyone can tolerate them. There are unfortunately some GI side effects, nausea, indigestion, constipation, that are typically mild to moderate and improve with time, but unfortunately not in everyone. And the medications don't have as robust or any response in about 10 to 30% of patients. So, sometimes surgery is necessary, and I refer more people to surgery than I ever have. I didn't know how safe it was. I didn't know how effective it was long term. And unfortunately, these GLP-1 medications are looking to be very expensive still for a long time. It is going to be a long time before they're available generic. And I would not recommend compounding or anything like that, as that is not FDA regulated and we cannot ensure its safety. But after surgery too. So patients who have a suboptimal response after surgery, we can intervene with medication there, and we're finding that patients are losing more weight. So once they plateau, combination medications are more effective, and bariatric surgery is like another medication. It's like another combination. So the medications can work as effectively, if not more, in most patients that have had bariatric surgery. We have to be more cautious, right? In over suppressing appetite in this class of patient. But that's why you want an obesity medicine provider prescribing these, whether you've had bariatric surgery or not.
Mm-hmm. And I think those are great points, Kristen. And I think the strength of our program is we are an obesity management program. We don't just focus on surgery or medications. And many of your primary care providers or endocrinologists may be prescribing some of these medications, but our program has a comprehensive team, multiple disciplines. And so we can prescribe and monitor these medications and see what fits for you at different times. And I think while we're kind of on that subject, before I go back to nutrition, a lot of people, like you said, don't have coverage for these GLP-1s. Is that all there is out there? Or aren't there some other things that they can try, maybe in combination, with surgery? Is there anything else in terms of the medications that are options that may be covered?
I mean, there are the first generation weight loss medications that offer about 5 to 10% weight loss. Contrave, Qsymia. These are medications that work more on reward centers in the brain versus the GLP-1 medications that work in our gut and talk to our brain. So they work more on reward pathways that can promote weight gain or increase in intake. So they work much differently. They are also proven safe in patients without cardiovascular disease. They're definitely not for everyone. Or sometimes we use medications off label that are for other indications, like Topamax or topiramate. That's often a medication that is actually FDA approved for migraines, but people lost weight. And we have a lot of robust clinical evidence that it is effective for weight loss. Also, metformin is a classic. It is very inexpensive. So I know everybody wants to drive around a Cadillac, but sometimes we have to get around in a Taurus, and we might get there a lot slower. We might not get as far, but some intervention, even a 5 to 10% weight loss, can reduce your risks of comorbidities.
Absolutely. Those are great points. So be sure, ask about more than just, sorry, I logged on.
Kind of goes to that menu of options, right?
And I know some people who have maybe tried Mounjaro and it didn't work for them. I think we had a question that involved that. And it said, my desire to eat far outweighed the effects of taking it. What else can I do? So some of us have hypertension that is difficult to treat with medication. Some of us have obesity that is difficult to treat with medication. So depending on your comorbidities and your BMI, surgery may be an option, or maybe a medication in a different class like the Contrave, phentermine, Qsymia that I mentioned, but also making sure that you're getting to the highest dose possible of some of these medications. Sometimes the lower doses aren't effective for people. So that is when you've tried a medication, maybe combination medications may be more effective for you, or surgery if you're a good candidate. So I would see someone like me that specializes in obesity medicine so that we could help.
Excellent. So going back to you, Lindsey, there were some questions about diets. There's vegetarian diet, Mediterranean diet. Which one is the right one? Should we be doing this at all? What is your take on dieting in general and the various types?
So there's tons of info out there, and there's tons of diets that are going around and people saying do this, do that. And I think the best place to start is with your primary care doctor and the rest of your team that you're working with, first of all, because you want to make sure that you're not doing something that may be harmful to maybe something that's going on with your medical history. In addition to that, working with a dietitian so we can look at the whole picture. We may think that, yeah, maybe you'll do really well with maybe this type of regimen, but maybe that won't work as well for you after we look at a food journal and kind of dissect maybe what your habits look like or how much of whatever macronutrient you may be taking in more of, and to kind of work with you on that to kind of balance it out to better benefit you as a person and the life state that you're in currently. Like the Mediterranean diet might work for person A, but it may not work for person B. So we need to make sure that we're looking at it in a collaborative effort amongst the rest of your team, not just one thing. And that's a question I get a lot. Like, should I be doing this? Should I not be doing this? Well, let's look at the bigger picture. Let's see what we're missing. Maybe we can improve here. Maybe we can improve there.
And that's what I love about our dietitians is they meet you where you are, right? We might all know the perfect diet is this diet, but I have to serve a lot of chicken nuggets in my house because I have a 6-year-old. So maybe the Mediterranean diet isn't right for me at this moment, right? And I need something with more flexibility. So I love that our dietitians, whether you're having surgery or not, they will personalize your diet plan or your meal plan to make it specific to you and your body weight and your preferences.
Specific and realistic. Realistic is the biggest thing. We can see all of these trends happening, but how realistic and how long-term is that going to be for you? If we're only going to meet a few times and we only have so much time, what can be the most realistic change for us to establish now so that it can carry over?
From like fasting is the hot thing right now, right? And that is not right for everyone to do. It may be good for some people, but getting some feedback from a medical provider or a dietitian to help guide you in doing it the correct way and doing it the safest way for you, making sure that you're getting adequate nutrient and protein intake so that it might work in the short term, but you may be causing harm to your metabolism and body in the long term.
And then what happens from an emotional standpoint, if we have something that's too restrictive, people can't follow up long term. They kind of fall off the diet and then they feel ineffective. And then they're stuck in these weird dieting, restrictive eating, binge eating cycles. So the dietitians, I think all of our team we aim to provide structure with some flexibility in there to be realistic.
That's a great point, Nini, when you say kind of the food addictions or kind of the binge eating. And a lot of people had questions about what are some tricks to like not just eat when I'm bored or emotionally eat or binge eat at night. What does your team tell people to help with that?
So one thing I just want to point out, food addiction is actually not a diagnosis. And there's still some literature to look at. Is there addictive qualities? Is there not? Is an addiction? It's not treated the same way as other addictions because guess what? You can't go cold turkey off of food, right?
Ah,
You can for smoking, you can for drinking. And so it's a little bit more complex. With that boredom eating, I'll just give a quick technique that we use. It's called delay distraction. So step one is you're identifying, is this a craving or is it hunger, right? So a craving is up here. Head hunger, desire, craving, habit, I want, and it tends to be very specific. Hunger is here. My gas tank is empty. And people usually get some physiological cues. The stomach is growling, maybe low blood sugar. If you're hungry, eat something. Eat something balanced, eat something with protein. That's really important. If you're recognizing this is more of a craving, you're going to go to step two, and that's going to be to set a timer for 10 minutes. Step three is really important. Find something to do. You're not just sitting and staring at your timer for 10 minutes. So you may go check email, make a phone call, go tidy up around the house. When the timer goes off, we go to step four and you're reevaluating. And that gives a little bit of what I like to call a speed bump to slow people down and make a better
And
decision.
I would be interested in the chain of events that led up to binge eating or overeating, right? Like a lot of people are more prone to binge eating if they have a disease like PCOS or sleep apnea, right? So looking at or if you have anemia or some kind of nutrient deficiency, cravings are complicated. They can be because of insulin resistance, neurological, hormonal, biological. So did you get enough sleep the night before? Did you skip breakfast? Like what led up to this and what can we do about it in the future?
Yes. Love it.
Yeah, that's excellent.
Often far more complicated than people would think. It's not as easy as choosing to eat or not eat.
Yeah.
So true. And I do have, and we have a couple more minutes left. I want to just ask about a common question for Lindsey about pregnancy and why people need to delay that. But just to kind of go into what you just said, a lot of people come in with so much shame, and we really want to break the shame and the stigma off of whatever your weight may be, your obesity. A lot of times you feel like you're a failure, you lack willpower, you may think people look at you as lazy, you may eat less than the next skinny person you know, and it's like, what the heck? A lot of times we are fighting a biology. It's not just eat less, work out more, do it. We have people who come to us. Yeah, genetics, socioeconomic, your health conditions, what medications you have to be on. This is a multifactorial condition, and obesity is a chronic disease. This is a chronic disease, just like some of the other medical conditions we deal with. So, for those of you who might come in with shame and guilt, we will not shame you or guilt you. We understand the background and how obesity works and develops, and we really want to educate you and empower you so that you can make the right decision for your health. And that's really a big thing that we all will drive home at all of your appointments. You'll be treated with respect because we don't think you're lazy or you lack willpower. You need help, and we're here to give it to you. One more quick question that I get all the time that I almost forgot about: pregnancy. Can you get pregnant after surgery or some of the medical treatments, or do you have to wait? And why do you have to wait? I'm trying to get, some people trying to get pregnant ASAP. So can you talk to us about that, Lindsey? Is it because of nutritional concerns, or you want to make sure they're not deficient?
So it's a mixture. So I can definitely touch on the nutrition side of things. There is a concern over fetal growth with nutrient like malabsorption. So with having a bariatric surgery, you're not taking in as much anymore. So we need to make sure that mom's getting adequate nutrition and baby's also getting adequate nutrition on top of what pregnancy needs as well. So we want to make sure that we're all on the same page and working towards the same goal of a healthy pregnancy. So we need to make sure that we're establishing that ahead of time, as well as checking with your providers consistently. So we see mom first through each trimester, and then we follow up with her 3 and 6 months postpartum, depending if she's breastfeeding or not, to continue to ensure that she's getting enough nutrition and nutrients via vitamins and other things like that. But I will pass that medical portion on to Kristen as to why the weight and all the other things.
Well, ideally, you just want to wait at least 12 to 18 months for pregnancy, just because it's not healthy to lose weight while you're pregnant. It's as simple as that. So, and it does happen sometimes, and we have to work very closely and have more appointments. But for the most part, and after pregnancy, I mean, there are 3 times in our life we're guaranteed to gain weight, and it's pregnancy, puberty, and menopause. So we're going to gain weight, unfortunately, with that. And we'll intervene sooner. Like I was saying, life events happen, but that's why we're here.
Excellent. It is 6:30. We have hit time. There is so much more we could discuss, but thank y'all so much to our experts and panelists for just sharing your knowledge and wisdom. And I really do hope that everyone who sees this is really empowered and educated about treating obesity. And so that concludes our Cleveland Clinic Ask the Experts event. Thank you so much for attending. We will send you a post-event email in the next couple of days with important information about what you just heard, links to all kinds of obesity and weight loss management resources, and details on how to make an appointment. And it'll also include a link to the recording for this event so that you can view it again. Thank you all so much, and good night.
Thank you.
Bye.